we'll just give everybody a second to join. I see the numbers going up on the participants, so looks like everybody's getting linked into the Zoom meeting. Great. I think I see the number stopped moving upward. So I think everyone is now in that is joining the meeting. And it's my pleasure. My name is Garen Stone. I'm the Global Medicine Program Director here in the MGH Center for Global Health. And it's really my privilege to welcome you all to the first MGH Global Health Grand Rounds of 2021. Say Happy New Year, despite the inauspicious times in so many ways and the challenging times. We are really excited this morning, though, to have Ms. Loyce Pace join us as our first speaker for this year, and it's really a privilege to introduce her. We will be putting the CME information in the chat, and we also invite you to place any questions in the chat. When we get done with the talk, we'll be moderating a question and answer time. And really appreciate everyone coming and joining us this morning, including from all around MGH and the Department of Pediatrics, who really kindly try and cancel their grand rounds for this morning to join us for this time. It's my privilege to introduce Ms. Pace. She is a public health policy expert and currently serving as the executive director of the Global Health Council and a member of President-elect Joe Biden's COVID advisory board. She's an expert in global health equity, working to promote equitable access to health care around the world. She's worked on the ground in more than 15 countries, delivering health programs and mobilizing advocates. She's previously held leadership positions in global policy, strategic partnerships at the Livestrong Foundation and the American Cancer Society. Additionally, she's worked with Physicians for Human Rights, Catholic Relief Services. Over the course of her career, she's championed policies for access to essential medicines, testified before congressional global health appropriations, and elevated the voices of the people at the community level around various shared advocacy goals. She's been recognized by the Union for International Cancer Control as a young leader at the World Cancer Summit, been an expert advisor in high-level forums hosted by the World Health Organization, the U.S. National Academy of Medicine, and other policy-making bodies. While her career path includes degrees from Stanford University and Johns Hopkins Bloomberg School of Public Health, in preparing for this introduction, I also learned that she has ties to Massachusetts as a graduate of Phillips Academy Andover. It's my pleasure and honor to welcome her today to MGH Global Health Grand Rounds. Thank you so much for joining us, Ms. Pace.
Thanks, Garen. I really appreciate the invite from you both and from you and Louise both, and obviously people behind the scenes like Carrie and others who helped make this happen. Good morning, everyone. At least for me, it's morning here in Washington, D.C. I have to say as well, goodness, these numbers keep ticking up. Wow. You know, I was really happy to be invited to do this, partly because of my ties to Massachusetts. I really did enjoy my time in New England, weather notwithstanding. The fall more than made up for it. But importantly, because I know that there's so many of you who really care about this work. And, you know, I was sort of taking a glance at the attendee list as well, trying to see if there are names I know or recognize. I certainly admire the work and the community that's come out of MGH on the topic of global health. And so I think I'll be among kindred spirits here. I'm often reticent as well to sort of show up somewhere as a so-called expert. I am still very much learning myself, and I guess I consider myself more as a conduit or, you know, someone who can facilitate these conversations among the group of us who again are really invested in not just the work, but doing the work better. And so that'll be kind of what I focus on today. As you all can see from the topic and from the objectives, I'm really hoping we can dig into what global health means in this moment. Obviously, we've all been really shaken, I think, by current events and really awakened by sort of the pile-on of crises this past year. We still have a bit of a road ahead as well. And so it's my desire to really look back on 2020 in some ways and ensure that we are learning some lessons real time, but not only for COVID-19, for global health broadly, because I think at the end of the day, we obviously are fighting a pandemic, but it's revealed a lot more about what we're all trying to do in this space that'll hopefully inform, again, how we how we do that better. So hopefully I won't raise more questions than answers, but again, this is about all of us, and I will gladly try and fill the time. I don't usually tend to do lectures, so I hope that we can also save a good chunk of time at the end to have a good bit of back and forth. With that, let's get into it. So first, I wanted to start with this premise of global health justice. Again, I think this is a term that's more widely used, particularly by those in this room. But just a level set, I like to step back and think about what this means for me personally, but then also sort of broadly how folks have been defining global health justice. And going back to WHO, they talk about the absence of avoidable or remediable differences among groups of people. At least that's how they start when they talk about equity and global health equity. But they try to clarify that it's not just about these inequities, or more. It's more than inequality. They say it's really about a failure to avoid or overcome those inequalities. And I really wanted to start with that definition. It really resonated with me too, because I think we hear a lot about sort of the gaps, what's missing, sort of how to close those, I guess. But really, when we think about inequity and justice in particular, I think it's important to acknowledge that oftentimes these solutions require choices, political, social, and otherwise. And it's really about sort of our collective failure to make those choices that can be helpful for people. But ultimately, I believe health is a human right, and I think that is an increasingly held belief. It's certainly where WHO lands on this, and I know it's not universally held, but again, given recent events and current events, frankly, I think people are really questioning the sort of connection between human rights and health in a critically important way. So hopefully we can get into that a little bit too. But I think going from this definition of health inequity, I wanted to talk a little bit more about what we're seeing in the COVID crisis. So Carrie, you can go ahead and go to the next slide. Thank you. So I think these numbers are going to be familiar for people, but obviously if I'm going to have a talk about equity in the wake of COVID, you got to talk about the numbers behind the numbers, if you will. So we hear the sort of headlines about how many people are affected in our country, for example, let alone around the world. The US is over 20 million cases, over 300,000 deaths. It's really quite dire, and it's really been quite hard on our country, and again, it's around the world. But if you look at this table that's pulled from the CDC, and unfortunately, I think a lot of us are familiar with some of these numbers. We see that, in particular when it comes to sort of a breakdown of COVID by race and ethnicity, that there are serious inequities here. And you have this striking sort of case around the rates of COVID, the deaths caused by COVID being 2 and 3 times that of their white counterparts, depending on if you're looking at sort of American Indian or Native American groups, Black Americans, people of Hispanic or Latino, Latin descent, Latinx populations. And so that's, one piece of the pie, or one chapter of the story. But then we can't forget that, whether we're thinking about just rates of COVID to begin with, or hospitalizations and complications from COVID, you're really seeing the burden of this disease really be felt by some communities more than others. And again, it's unfortunate that this is a story that we all know all too well, and honestly could have predicted from other health conditions or crises in our country, and yet here we are. And I have to say too, this isn't even reflective of all the data that could be gathered, because we do know there are limitations in the data, and I know a number of people are advocating for better data collection. Even these numbers are sort of a bit off from the COVID dashboard or the racial data tracker that I know at The Atlantic publishes. But suffice to say, even if you look across different data sets, it's telling the same story, and it's really pointing us to a problem that needs fixing. If we go to the next slide, you'll see that I tried to include some of that information from the Atlantic's tracker, and specifically for Massachusetts. And I have to say, I was, again, you guys are probably really familiar with this data. It's really good to see, obviously, that you're one of the states, at least according to this particular database, that's doing a decent job collecting those numbers and really looking at disaggregated data. But you see, for example, the rates among Latinx groups, and I would really want to hear, and this is in particular sort of the case rate versus their proportion of the population in Massachusetts. And I really would want to hear from you all how you're looking at this, how you're tackling this, because I think that's a pretty startling number. And I think if you look across states, you'll be able to see, obviously, across different racial and ethnic groups, kind of how these different groups are being affected. I think what's incredibly important is not just the numbers, obviously, but what's behind them. So what's really driving these rates? We can think about things like comorbidities, obviously, but then we also look at sort of risk factors, and even beyond those, kind of the social and probably better said structural determinants of health that drive these things. So, occupational risk, whether you refer to people as essential health workers or other workers on the front line who are critical to the response or to sort of keeping us all afloat throughout COVID-19. There are people who are sort of disproportionately exposed, obviously, to this virus and thus disproportionately affected, let alone the fact that certain groups don't have the ability or luxury to stay home, keep their kids out of school and daycare, sort of keep their distance in terms of their housing, and the like. And so I spend more time on this because I do believe that anything we do around the world needs to start at home. Global is truly local, and vice versa. And so and because the US is really a country that's standing out for the wrong reasons lately when it comes to this pandemic. And so we really do need to look at ourselves with regards to how we've showed up in this moment. But with that, we can go to the next slide and look a little bit more at the global data. I really appreciate what has come out from UNHCR and the High Commissioner for Human Rights, Dr. Michelle Bachelet, former president of Chile. And she's talked about, in different forms, about COVID does have sort of an uneven impact across communities of color around the world and indigenous groups around the world. There's data that's come out of Brazil, looking at districts like Sao Paulo and how I think their Black community is, or people of color, broadly speaking, is 62% more likely to die from COVID, which is, again, striking, but somehow not surprising. I was in a forum recently with a representative from the French government who was offering numbers with regards to racial and ethnic backgrounds or breakdowns in their country that kind of are telling a similar story. Same with representatives from the UK, at least advocates there who are trying to track this and arguing for their government to do a better job tracking this information. But the sad news is this is something that's affecting the diaspora, if you will. And I recognize too that the discrepancies or inequities around COVID isn't just about people of color. I think it's really important to acknowledge how women are disproportionately affected, and this is not necessarily with regards to their numbers in terms of case rates, but when we think about the ripple effects of COVID in particular, how women are, a lot of women around the world are part of the informal workforce. Even if they're a part of a formal workforce, they're asked to stay home. And so there's a loss of income there. You had some reports, early reports, unfortunately, coming out of the UN around gender-based violence because of, sort of their exposure to risk for that by staying at home. You obviously have ripple effects on children who are not able to go to school and who are really losing ground in terms of not being able to have an education at home, let alone other issues around immunization and nutrition programs. And so, there are poor people, Black and brown people, there are LGBTQ people, there are people who, aren't, don't have secure housing and the like, who are all affected by this in really unfortunate ways. And we have to keep them in mind as we do our work. And again, I know that people here are doing that, but I think I am trying to do a better job telling that story, the fact that we are not all sort of like affected equally. And yet we need to, because of that, we need to really think about a more equitable response. So that's the sort of context I wanted to offer as a starting point. I think what I wanted to do next was actually dig a little bit into sort of the global health architecture. Because again, this is sort of thinking about not just COVID-19, but how global COVID-19 is affecting our industry, our community, and our work. But I didn't want to go straight to talking about global health programs because when we also think about inequity, I think it's important to sort of look within and kind of talk about equity from the inside out. And so I wanted to spend just a minute on global health leadership and sort of what we see as a snapshot there. And if we go to the next slide, you'll see I tried to pull together sort of a mosaic of faces of people who represent a number of global health organizations. These faces in particular represent leadership across organizations that are members of the Global Health Council, which I think Garen said is a membership organization based here in DC, focused on advocacy for global health. But when we did a quick snapshot or survey last year of our membership, and we have about 100 organizations who are members, we found that just about 10% of that leadership is comprised of people of color. About half of whom were Black. We were looking specifically at Black leadership at the time. But it's not, it's not a big number, considering that the work that these organizations do is really focused on Black and brown and Indigenous communities. And so, I know that there are groups who have looked at the leadership of women in global health, which has been critically important. We haven't even really gotten to the fact that a lot of these spaces do not represent people in low and middle income countries where this work happens. And so I think my point is probably not surprising, is that there's some work to do. I'm happy to be in this role, for example, as one of the few individuals who checks a box or a couple of boxes, if you will, but that's not nearly enough. I don't check enough boxes, frankly. And also, sort of one or two or a handful of us cannot represent an entire community. And we all know how critically important it is to inject diversity in leadership so that we can ensure the work we do really reflects and addresses the wide array of needs that exists. I'll say one more thing though about that before I move on, and it's a point that one of my team members actually raised as I was talking to them about doing this presentation. And she said, I think it's really important for you to talk about what people of color, leaders of color face, honestly, in these positions. And even if you go back to someone like Tedros, whose picture I had up in the previous slide, there's an open question of whether he would be facing the same type of, not just scrutiny, but ridicule that he has if he weren't a leader from the African continent. You also have data that was released recently by Bridgespan and Echoing Green in Stanford Social Innovation Review that talked about sort of like how leaders of color aren't supported, even in moments like now, where they're really trying to provide support for Black and brown Indigenous communities. They don't get as much money. They're sort of held to higher standards. It's that common refrain of twice as hard for half as much. And so I do want to lift that up as an issue that, has been sort of widely communicated or broadly communicated, but not necessarily addressed. And I'm hopeful that in lifting up these people of color as leaders, that we also recognize some of the limitations that they face as leaders, and try to prevent the burnout or the other barriers that even people have at a high level. So that's leadership in global health, or one facet of leadership in global health that I wanted to call out. But another solution to that problem, to the problem of diversity or lack thereof in this space among our leadership, is sort of flattening the structure itself. And so this is where this idea of democratizing global health, I think, comes in. This is a snapshot from a summit that we held last year in 2019. Having recognized that it was important that a group like Global Health Council and organizations here in Washington, kind of touching people in power, really adopted what, frankly, people like you started. So I know that you had Decolonize Global Health really come up, or bubble up, I believe, from the Harvard community and students in and around Cambridge and throughout Boston. So I really want to sort of call that out and say how much I appreciated that leadership. I think that caught fire in places like Duke and, across the pond in the UK. I know Hopkins recently had a summit. And so I think it's really important to acknowledge that a lot of these calls and cries for decolonizing global health really started with new leaders and really inspired people like me to stand up and to use whatever platform that I could to sort of shine a light on this very issue and try to do my part in decolonizing global health. And so that's kind of where our journey in this space of equity really began. Of course, me coming in several years ago, I always sort of had an eye or ear towards this issue, but I didn't necessarily know how to try and unpack it, frankly. And it truly is a sort of a development industrial complex down here in Washington when it comes to global health. But I applaud leaders here and even those CEOs that you saw on the screen previously for wanting to step in and step up in this space. People are ready to listen and people are wanting to do better. I think it's still going to take some work for us to truly dismantle some things here, but I think bit by bit, brick by brick, and even with our political leaders, we can try and make that happen. So the next piece I want to get into is around another important facet of power, and that's this idea of who holds the purse strings, right? So there's like sort of who's at the top, who's making decisions, and then who's who's really doling out or controlling the resources that make this work happen. I wanted to focus on this because we did a video series this past summer with leaders in the field and specifically Black leaders in this space to kind of get their sense as to what we could do to decolonize global health. And I spoke to a dear friend and colleague, Angela Nguku in Kenya, who said, look, it's essentially blackmail, what goes on in global health. And so I thought it would be important to dig in to some of those kind of funding or financing issues that she called out. So if we go to the next slide here, you'll see I pulled some information from IHME, and for people who don't know, there's a group, Dr. Chris Murray's group out of Washington does these annual reports on kind of where and how the funding flows in global health that are useful in a number of ways. And they also do a fantastic global burden of disease report that tries to understand how the funding matches the need. But I just wanted to look at the funding itself for now. And, when you look at this slide, for example, you still have the US leading the way, actually, when it comes to who's sort of contributing the most to development assistance and health. And then you have sort of other usual suspects follow suit. I have to also, flag for those of you who don't know that as part of their analysis, they pull out the Gates Foundation, given the, where Gates falls in their contributions, which I think is, telling in a number of ways. But I also wanted to show this particular slide because, you know, I hear a lot of people who, in offices, in congressional offices here in Washington, you hear a lot, well, you know, we owe it to the US taxpayers to help them understand where their money is going. And ergo, we, you know, they deserve a right to sort of dictate this work in global health. And so I think that gets to Angela's point of this feeling of blackmail or, you know, having so many strings attached. And I think what people are trying to do here in DC is understand kind of what that balance should be. I don't think anyone is saying there shouldn't be any, I guess, so-called accountability of the work, and yet what does accountability mean? Who's driving those metrics and sort of this sense of success on what timeline? You know, these are the questions I think we're trying to unpack when we talk about kind of decolonizing in the space. So if you go to the next slide, it's telling a different part of this story, which is where the money goes. And this is, I think, where you have groups talking about this sense or feeling of, you know, new colonialism in global health. And it's not to say well, people shouldn't help at all, or, you know, I think having this kind of either or framework is less productive. But if you have mainly Western countries are giving the bulk of money mainly to, you know, countries like countries throughout Africa, for example, then there's a question of the power dynamics. And I think that we've seen that play out across global health programs in a way that a lot of these partners really want to try and, again, kind of move away from as much as possible. So I think there's a question of how much we can even just work in partnership with these countries versus kind of leading in a top-down way, in a way that might feel naturally dictated by the power dynamics that come across with these funding flows. And then when I think one of my last slides on this, if you go to the next slide, is about sort of who is then receiving the money to do the work. And so again, you have a lot of money coming out of the US, a lot of which is going to countries across Africa, a bit throughout Southeast Asia. But then you have a lot of that funding going to US-based organizations. And even more so, a lot of those, even more so, when you look at this chart, you have say 80, close to 90% going to US-based entities. Half of that is actually going to just 12 organizations. And so it's been really concentrated. Granted, there are some multilateral groups as part of sort of the top 20 list that USAID awards, for example. But really, agencies like USAID, and I think in other parts of the world, have been trying to better localize or decentralize this work. Not only because, I mean, I think there are a number of reasons for it, and I think effectiveness is driving some of those decisions as well. And this has been true for both, say, the Obama and Trump administrations, for that matter. I wanted to spend some time now talking about the global health architecture beyond the funding and shine a light on some of the programs that we know and maybe some of the programs that we don't to start to move into, okay, well, how do we change? How do we shift? You know, how is this evolving real time? So if you want to go to the next slide, Garen, that I thought it would be important to, you know, look at these major programs, the top 3 initiatives that we all know and many of us really respect in global health. There's PEPFAR, there's the Global Fund, there's Gavi. And just for people who might not be steeped in this, all 3 of these initiatives were set up about 20 years ago and driven largely by stakeholders in the US, but in partnership with you know, folks around the world, which has been really great to sort of work internationally and in international cooperation towards these objectives. You have PEPFAR, which has been really the largest commitment still to date on a single global health issue that was established by former President Bush at the behest of groups like the Congressional Black Caucus and faith and LGBT communities. Back in the early 2000s, you have PEPFAR now, I think, totaling more than 90 billion that they've given to the fight against HIV/AIDS, and so that's been really quite spectacular. And the U.S., given it's our flagship program, has been the largest donor during that time. And you have PEPFAR having done some good work then as well. I think is according to one of the recent reports, they have put people on about 17 million people on ARVs over time. And so, it's not without progress or results that PEPFAR has come to be and lasted this long. And then you have the Global Fund, which is more expansive, is really looking at not just the fight against HIV globally, but also TB and malaria. And they've doled out about half the amount of PEPFAR, about 45 billion. That's come from a number of donors, the US being a major contributor, but with other countries participating as well, as we sort of saw quickly in one of my previous slides. And their work is really, again, spanning almost across the entire globe, over 150 countries, where they are really trying to advance or make progress in their main 3 diseases, but also, as Peter Sands, the current director, will tell you, also in health system strengthening, particularly so that countries can sort of build on these existing platforms for infectious diseases. And then finally, you have Gavi, really driven by Gates and then others who have joined to advance childhood immunization that had really stalled a couple of decades ago. And now you have Gavi vaccinating, I think, close to half the world's children, which is amazing, as well as leading the way on even vaccine distribution for something like COVID-19. So, each of these institutions or initiatives plays a really critical role in global health and has largely defined global health as we know it today, particularly when it comes to infrastructure. But if we go to the next slide, I wanted to also be sure to give people a sense of what else is out there. And these initiatives, rather than coming into being the past 20 years, they've really come out in the past 5 years or so. So they're a lot younger, and I think that people are still kind of trying to understand what progress they've made, but they're structured quite differently. So you have something like the Global Health Security Agenda, which is depicted by that first sort of orange swirl logo. And that was set up in the wake of the Ebola crisis, and you had the US really behind that, but it wasn't something that we felt we needed or wanted to own. It was something that was established more using a secretariat model. There are a number of permanent members and countries who are members, and then some rotating members, but the secretariat or leadership itself kind of moves around that group. I think the current secretariat is Indonesia, if I'm not mistaken. But they host meetings and they set goals and they sort of track their progress. And, a lot of people credit, well, there's been a lot of criticism or some criticism of, the global health security framework and whether or not it failed us in the wake of COVID-19, which I think is incredibly fair. There's also a question of whether by kind of relinquishing control of something like global health security and GHSA in particular, we enabled countries other than the US, frankly, and low and middle income countries to be more responsive and to really demonstrate their capacity and leadership in this space in the way that they might not have been able to had this been sort of US owned or, owned at sort of a Geneva or a global level. There has been another initiative that also was established around that time, maybe around 2015, the Global Financing Facility, that currently sits at the World Bank, but has involves players like Gates Foundation and others, who there's WHO and others around the table who are looking at how we can, instead of kind of dictate what countries should be doing, and specifically in certain disease areas, allowing them to develop their own national plans, and then asking sort of a group of donors, or sort of this fund, if you will, to then fund their local priorities or national priorities. It's not that novel of a concept, obviously, but I think people finally recognize that, and countries demanded that, hey, it's been great to focus on things like HIV and nutrition and the like, but there are other issues that aren't getting attention or investments, frankly, because of the way global health has been structured the past couple of decades. And so we'd really like to be driving this, we'd really like for you to trust us in this. And so, you have this group who looked specifically at women and children's health and adolescent health, and said, okay, well, let's try this model. How about you tell us what's needed across this special population, and kind of dial up or down these priorities, and we'll come in and fund you for that. So I think there are about 35, 36 countries now who are involved in global financing facility, with sort of varied results. But I think people like me have been encouraged by this model because it feels more locally driven, more inclusive. There's even a CSO sort of seat at the table when it comes to dictating these goals and these agendas. And so I'm hopeful that it can emerge as a model that, will be helpful for us moving forward. And then finally, there was a global action plan that was launched last year. And that was an attempt of all of the various UN agencies who work across global health to come together and frankly, at the behest, again, of countries like Ghana, but also donor countries like Germany, to say, hey, we're kind of all over the place in global health. And again, a lot of good has been done, but we're now starting to trip over ourselves, and and maybe undermined all of that good work. And so what we'd like to see you do, UNICEF, WHO, Global Fund, Gavi, and the like, is look across your various priorities and resources to understand how you can be better coordinated in service to some of these country partners and communities where you're all working. So that's the newest initiative. And so that is, I'm less clear on how successful that has been or will be. I think a lot of us are concerned that they're still struggling with how best to cooperate, given that there are such clear kind of individual institutional agendas. But we'll see. I think that's what's needed, obviously. And I think COVID has kind of pushed a lot of those same agencies to come together in unprecedented ways, and hopefully in ways that will be successful, but will also continue to the benefit of other global health programs. So speaking of kind of those other global health programs, oh, sorry, you did fine. You can go to the next slide. Ultimately what we want to do is make sure we evolve, right? We learn, especially real time, kind of where we need to go from here. And so I wanted to close out the talk by, giving you my sense, or our sense at Global Health Council, what that future could look like. But again, want to certainly hear from folks around the virtual room, your take on this as well. I want to start with the people, which is kind of where I started this whole talk. And if we go to the next slide, I wanted to spend a bit of time on, frankly, I talked about sort of working from the inside out. This has to come from GHC too, right? I can't be just out here preaching the gospel of changes in global health. I really want to be sure we're demonstrating it. And so again, I think change does start from the top. And I think for those of you who were involved in our summit this past fall, you saw me very deliberately wanting to show what leadership looks like in global health from my perspective. And this wasn't the first year I've done this. I think it's the first year people really noticed. But we had a summit with, I was very clear about wanting all people of color, and it turns out I ended up having all Black leaders, I believe, as part of our annual summit on global health, and not just talking about diversity in health or inclusion in health, but talking about global health security and talking about sort of other facets of the work that we do, policy and advocacy and the like. And so, I think a lot of times we hear this lamentation that there aren't enough people in the pipeline from which we can draw, and that's just not true, I find. So, hopefully this inspires others to do something similar. And in fact, I've had people reach out and say, oh, okay, well, who did you have talking about this issue again? Because it's not just about me being out here doing this, right? Remember, I'm one of 5 or so Black leaders in this space. I want others to be brought to the stage as well and given the mic as well. And I'm glad to hear and see that that's happening. If we go to, I think we can, if we go to the next slide, this is just a snapshot of the video series that I mentioned, where I, talked to some of those leaders about the changes we need to make. And I just want to sort of encourage you all, if you haven't already, to log on and take a listen, because I found that very powerful, to talk to different people in our space about what they see are the needs. But I also wanted to lift up work that others have done. So this is not just about GHC, but it's about, again, all of us collectively sort of pushing or pulling for meaningful action. I talked about the student-led or young professionals leadership previously, and there was this great piece in BMJ around decolonizing global health. I think some of you here might have been a part of that. I know there were folks out of Boston who contributed, but I think it was, coming out of Duke's sort of decolonized global health efforts. And I just found it really powerful and really practical, frankly, in terms of like how we move forward in this space. You also have Madhu Pai, who's quite prolific in this space, coming together with others to talk also about how we really evolve in global health, particularly in light of COVID-19. So happy to provide links to some of these resources after the chat, but wanted to be sure and lift up those writings and recommendations as well. Moving on, I think part of the change we wish to see is in the people, but those people drive the policy. And, in addition to having folks authoring these papers or proposals on how global health should change, you also have us at GHC trying to show up with a diverse group of stakeholders, advocates to decision-making tables. And you have forums like the World Health Assembly, where we have brought in people to really try and drive what change should look like based on their lived experience and their local realities. And again, this is, it's not meant to be gimmicky, it's meant to be effective, right? We intentionally bring women into our delegation. We intentionally have our member organizations assign someone from a low and middle income country to attend World Health Assembly, either sort of in person or now virtually, because we want to be sure these different voices are reflected. We have young people who are a part of our delegation as well, because we have to have sort of a multi-generational approach to this work. And so we try and do our part to ensure that the people at the table are making these decisions and again, helping to shift the power in terms of policy change. But then if we want to go to the next slide, one of the things that we want to do, and you can go ahead and click through and show all these boxes. I think there's 7 total, Garen, thank you. We also are mindful of the change that is required in global health programs. And we at Global Health Council have worked with a lot of those same people that I've already mentioned and our broader community to develop a set of principles for a new vision for global health that really involves that democratization of which I spoke, as well as really looking holistically at how we work across silos. And really, ultimately we want everything we do to be centered on the very personal need, right? We want to ensure that we're not just approaching all of this in terms of silos and priorities and the like, but what what people are really trying to manage on the ground, right? And so I'm grateful that, again, our community here has come together to try and shift our thinking in global health and ensure that we're driven not just by these metrics or these very what people like to call tangible results at the end of the day, but also are looking at some of the fuzzier stuff too, right? Again, who's around the table, who's driving this? And it doesn't mean that we can't hold each other accountable. We can't actually realize progress. I think it's just a different type of progress driven by a different type of person, frankly. And it also doesn't mean we abandon what we've been doing. And we think it's critically important that we still focus on the same global threats that we know we all face. But I think our goal is to create space for particularly what our community and country partners have sort of communicated is being left out. So that's our part of our hope for the future. And if we go to the next slide, which I'm gonna close out here with these last two, there's sort of a zoom out that I like to do anytime I talk about this in particular, which is why all of this matters. And if we go to one of my final slides, it's really, we know that we are not actually at the finish line for a lot of this work, right? And so, again, it's not just out of convenience we want to have different people around the table. It's not just, out of sort of a moral obligation that we want to close the gaps in health, but it's only by not leaving anyone behind that we'll honestly be able to report back to the US taxpayer or congressperson, hey, we did it, right? And so I think we're realizing that. We certainly see how I think COVID has exposed a lot of our shortcomings, a lot of those gaps we need to close, and the fact that we really are all in this together. And so whether it's around ensuring that we are addressing, again, kind of the big three, what we identify as current global threats, and ensuring that we're kind of doing so holistically and not leaving anyone behind, that's going to be critically important. But we also need to look towards the future and understand that global health threats, like the pandemic we're in now, need to be kept in mind, right? In addition to whatever else is coming down that we still have yet to see, unfortunately. So it's not just about these specific programs, but it's about building a better foundation for all of us to be able to absorb these shocks as they come, and they're going to continue coming, unfortunately. And then finally, one of the other things that we want to see is not just this change in the health space, but also how health can work in tandem with other development issues or priorities, whether that's gender equity, economic empowerment, climate change, and the like. And so I see a pretty bold, promising future for global health, should we be so brave and bold to step into it. And I'm encouraged by conversations we're having in Washington with elected officials, right? This is not just sort of a pie in the sky dream that I had 4 years ago, but now something in 2021 that I think we can collectively realize, should we be willing to do so. So with that, I think my final slide is just an encouragement to all of us that we look towards the future and do what we can to change the game in global health, because we can't wait. Thanks again.
Great.